Hello, and thank you for joining us in the second webinar of the series, Pandemic to Progress, Building Capacity Through Global Surgical, Obstetric, Trauma, and Anesthesia Systems. Today's webinar is Obstetrics During and After COVID-19, Delivering for Mothers and Babies. This webinar series during the UN General Assembly is presented by the G4 Alliance, the Global Alliance for Surgical, Obstetric, Trauma, and Anesthesia Care. Along with our partners, GICS, the Global Initiative for Children's Surgery, and the Program in Global Surgery and Social Change at Harvard Medical School. We have many partners supporting this webinar series. Today's webinar is presented with the support of Jhpiego, the Frontline Health Workers Coalition, and IntraHealth International. Today's speakers will be speaking in English, but you can also listen to this webinar in French or Spanish. To listen in French or Spanish, look for the interpretation icon, which will be either at the bottom of your screen on the right of your Zoom screen, or for some people, you might see it on the top left of your screen. The interpretation is generously provided by Operation Smile and Smile Train. My name is Laura Mukey, and I'm a member of the Board of Directors of the G4 Alliance. We have a great panel today. I'm really excited to welcome all of you to hear these great panelists, and you'll be able to ask them questions. We want to be really responsive to your questions. So to pose a question, please look for the Q&A icon, which again should be at the bottom of your Zoom screen, and type in your question there. We also encourage you to use the chat function, especially if you have comments that aren't questions for the speakers or moderators. So remember, questions in the Q&A and comments in the chat. I know most of you are probably used to using chat during Zoom meetings. So just remember, if you have a comment rather than a question, use the chat. Thanks. Now I'm thrilled to welcome our co-moderators, Dr. John Varallo and Dr. Isioma Okolo. John Varallo is Global Director of Safe Surgery at Jhpiego. He has a very illustrious career as an OBGYN. And one thing I really like about John is he talks a lot about surgical teams and the importance of teamwork in surgery and surgical care being an integral part of every functional health system. Welcome, John. And Isioma Okolo, who's a fellow with the Harvard Medical School Program for Global Surgery and Social Change. In talking to Isioma, I realized she really wants to bring a combination of surgical skills and public health skills. She's currently doing an MPH at Harvard while she's a surgical fellow. And she's worked around the country in really integrating surgery, public health, and social change. And now I'll turn it over to you, Isioma. Thank you.
Thank you very much, Laura, for that introduction and that brilliant opening to this session. So we have an amazing panel of leading thinkers in the world on this subject, and I'm really looking forward to introduce them to all of you. But first of all, I think it's important we set the stage by understanding exactly what's going on with obstetrics during and after COVID-19. So what impact has COVID-19 had on maternal and newborn health? Halting and reducing delivery of essential services, services which really, if you look back over the past couple of decades, have been key drivers in reducing maternal mortality, has obviously had a worrying trend in terms of the current situation and predictions for increasing rates of maternal and newborn mortality and morbidity. So these sort of key drivers and that have driven down maternal mortality include things such as antenatal care services, postnatal services, women attending for newborn checks, vaccinations, and family planning, which we'll speak about later on in this presentation. Furthermore, obstetrics is unique. Unfortunately, babies have poor time management. They arrive at all times of the day. And planning and postponing cesarean sections, for example, can be very difficult. Managing things around induction of labor, for example, can be very difficult in the obstetric population. So unlike our other surgical colleagues who could cancel elective surgery, for us, this was a big challenge. So unfortunately, what this is looking like then is a huge impact in terms of millions of lives lost for mothers and babies. But on the other side, looking at the impact it's had on frontline workers, so 70% of frontline workers are women. There have been issues around limited access to personal and protective equipment, adapting to new infection prevention and control measures which have not been applied uniformly across the globe. And amongst frontline workers in particular, heightened stress and anxiety around these issues around access, but also fears with regards to their own personal risks to their families, and just the ongoing rhetoric and narrative around limited resources is having a significant impact on the healthcare workers and subsequently the quality of care that they can provide. So something I found quite startling, looking into the research in the area, and be mindful that obviously this is changing every day, but some UNFPA data shows that with the 6 months of lockdown, disruptions in access to modern contraceptives could mean that 47 million women have reduced access. And you can only imagine what that would mean in terms of unintended pregnancies. Rates as high as 7 million have been predicted. Now, when you look at the research coming out with regards to COVID-19 and maternal and child health, there's loads of research groups around the globe, and there have been attempts at modeling what the outcomes could be in terms of excess mortality and morbidity. This is one from an early review in the Lancet showing an additional 60,000 maternal deaths and an additional 600,000 newborn deaths. And of course, this is predicted to increase as the pandemic continues. So in pregnant women, we believe that prevention and preparation is the key. And of course, this is the theme of these series of webinars. How do we, create pandemic preparedness with regards to surgical, obstetrics, trauma, and anesthetic care? With regards to pregnant women, we know that they might present differently to non-pregnant women. We also know it's not necessarily that they are at higher risk if they don't have risk factors, but when they do contract COVID-19, there's a higher risk of needing critical care, for example. Looking after a pregnant woman in critical care introduces some more challenges because the pregnant airway is very much different from a non-pregnant airway, for example. We know when we're looking at their babies that pregnant women with COVID-19 are also at higher risk of delivering preterm. So there's loads of factors to consider, and that's why I'm really excited to be opening the floor and to be having these discussions with our panelists who are experts in this area, and hopefully who will be bringing, as well as their expertise, their experience from working on the ground. So we'll be hearing in particular from the realities on the ground from Ethiopia, Rwanda, and South Africa. As I highlighted earlier, stories and challenges from frontline workers, and also, some of the practicalities around screening of pregnant women and the nuances around a COVID positive or a suspect test, for example, and also bringing in some realities about the impact of training of healthcare workers, something I'm quite interested in as I am a trainee doctor. So over to you, John.
Great, thank you so much, Isioma. I'm really excited about this panel, and it really is it's a pleasure and an honor to be a part of this the webinar. So I'm going to start with introducing our panelists individually, and then we'll come back and start doing some rounds of questions for each of the panelists, and have this as more of a conversation around some of the important aspects around COVID-19 and safe obstetric care. So our first panelist is Dr. Mekdes Daba from Ethiopia. Dr. Mekdes is an Ethiopian obstetrician gynecologist and public health specialist who has been in clinical practice for more than 10 years. She is a strong advocate for women's health and a current member of the RMNCH Technical Advisory Group for WHO Afro and chair of the Civil Society Advisory Group for UN Women in Ethiopia. Welcome, Mekdes. Our next panelist is Professor Salome Maswime. She's a head of global surgery at the University of Cape Town in South Africa. She's a South African obstetrician and gynecologist and the president of South African Clinicians Scientists Society. She was the Discovery Foundation MGH Research Fellow in 2018 and a recognized global surgery expert with her research contributions on cesarean sections. And I know that she has some interesting updates on some of the research she's been doing around COVID-19, so I look forward to hearing about that. And our third panelist is Dr. Madeline Mukey Shimano from Rwanda. She's a MNH specialist with IntraHealth in Rwanda, a medical doctor and national quality improvement facilitator with more than 8 years of experience providing direct clinical care. Works at IntraHealth International on the USAID activities supporting implementation and monitoring of MNH programs in 5 districts in Rwanda. So it's a very interesting panel that we have, frontline workers with a broad experience in obstetric care and working with COVID-19. So I'm going to open the round of questions. I'm going to start. The first question is going to be for Mekdes. So Mekdes, in Ethiopia, I know you've had a lot of experience with COVID. I know it's been a really challenging environment to work in. I'm wondering if you could share some of the what are some of the challenges that you are seeing in continuing to provide safe obstetric care, safe obstetric surgical care in this time of COVID, and what is Ethiopia specifically doing around that?
Thank you, John. Thank you, everyone. And as this pandemic just started and Ethiopia first reported the first case of COVID on March 13, and since then, there has been lots of things that were being done by the Ministry of Health and also professional societies like Ethiopian Society of Obstetricians and Gynecologists and Midwifery Society, and also have Ethiopian Society of Emergency Surgical Officers, and lots of different stakeholders have been trying to see and mitigate what we could do about how we can continue safe surgery, especially obstetric surgeries and essential services, and just to see what just happened and how we responded to this pandemic since it started or being reported in Ethiopia on March 13, as initially, especially the first 3 months were found to be more of a chaos, I would say, but because this is a pandemic and also it's like a big world pandemic that we were not prepared for. It's different for everyone. And of course, in Africa, as you've initially said, as Isioma was also saying initially, we had some experiences with different outbreaks like Ebola, in some preparations with different regions in Africa. But coming to Ethiopia specifically, some of the challenge that we see was initially restructuring some health facilities and the first 3 months were more about locking down everything. So it has greatly impacted. We didn't do like a big lockdown for nationwide, but when it comes to different services, it has contributed a lot because one, services were restructured, and the other one, people had some fear of even coming to institutions, which was a big challenge if you specifically see obstetric and essential services around obstetrics and other emergency gynecologic services too. And we have been in contact, and we were having updates with the Ministry of Health and Maternal and Child Health Department, trying to come up with how can we do continue essential services, how can we protect our providers, how can we still give safe surgery at the heart of this pandemic. So initially we tried to check if other experiences that has been implemented in countries other than Africa or in countries other than middle or low-income countries can be implemented in Africa or even in Ethiopia. So that was a big exercise, and that was a big challenge that we still are trying to learn. So just to update you of, if you might be wondering how many obstetric cases do we have, how many cases do we manage currently, we have around, as of today, we have 2 obstetric designated, COVID designated centers. So as I was telling you, one of the impact was designating facilities. Some would be COVID designated, some could continue their routine or essential or other services. So talking to the capital of Ethiopia, for example, for Addis, initially we designated 1 COVID center, which is a good thing to have because the number of cases was not increasing as of a day, but it's progressively, or it is increasing day by day. And a total number of cases that we have now is around 111 cases. So out of the 111 cases, if you are wondering how many safe surgeries we did until today, we have 2 COVID designated centers, one being Eka Kotabe and the other one is St. Paul's Hospital, which is the hospital I'm currently practicing as an OBGYN and a consultant. And we had in Eka Kotabe, we had like 10 deliveries, and out of the 10 deliveries, 6 were cesarean section. At Eka, they had like 45 cases. Out of those is what I'm talking. And they had like 4 normal deliveries. I think this is very important to disaggregate while we are talking about how much is our experience when it comes to like safe delivery and safe cesarean section or safe surgery in obstetrics. And when it comes to St. Paul's, for example, it was just started a few months after we had Eka Kotabe, which is the first experience we had there. And we came to see that if cases get complicated, if referrals need to be done, there might be so much problem. So we tend to bring referral or tertiary hospitals that can integrate all services like ICUs, like dialysis and other things. So St. Paul's is such a facility. So after it just started, we have like 66 cases, out of which there were 20 deliveries with 14 cesarean sections and 6 normal deliveries. And we had only 1 maternal days. Otherwise, that is for the whole country I'm talking about. So otherwise, which was from a case with severe COVID. Otherwise, most of the cases are asymptomatic, and this is where we are since the pandemic started. So the first 3 months were more of planning, putting guidelines, checking if it would work in our country. And then now we're starting to learn like triaging, how to do self-isolation, because initially everyone was being quarantined, which included even providers. So now we have shifted from what has been quarantining everyone to more of being logical and trying to see if cases are asymptomatic, they can be managed at home. So I would say it's more of learning through the curve. Thank you.
Great, thank you so much, Mukey. It's really interesting that kind of overview of what's happening in Ethiopia, and you've touched on so many important aspects that I think we're going to come back to. Even talking about like the organization of services, I think is really critical from a health system standpoint as well as within the facility itself. I think maintaining those essential services. I think another aspect that I'm sure we're going to come back to is around fear. Fear not only among patients, but around providers and how we help to address that. But at this, I'd like to now maybe turn to Professor Maswime, and if you can give us an overview of your experience on the ground in South Africa, and similarly to some of the challenges that you're seeing and how South Africa is responding to that. Thank you.
Right. Thank you so much. And also excited to be part of this panel and this important discussion. And so in South Africa, my work has really been mainly around research and the health system strengthening. And so in the beginning, I was part of there was a national team that put together the guidelines for COVID in pregnancy, and I was part of that team. I was also part of the national team that's running the South African COVID-19 in pregnancy study. And so broadly speaking, I mean, very similar to what Magda spoke about, you know, in the initial days, there weren't many cases, especially from the obstetric side. That also meant that, you know, there was less vigilance. And so, you know, less PPE or less guidelines on how PPE should be used and what is required. And so that also resulted in healthcare workers getting infected as well. And so some of the concerns in South Africa have been how to protect the healthcare workers, labor ward being a high-risk place, especially as mentioned, as we all know, you can't postpone deliveries, you can't really postpone elective surgeries. So how do you protect the patients? How do you protect the healthcare workers and all of these issues? So that has been, those have been really serious concerns. And I mean, also from a global surgery perspective, looking at other sides of gynae and the actual impact, the collateral damage as well for patients who are not attending antenatal clinic because of their fears. You know, what does that result in? Is it increased stillbirths? Is it increased maternal deaths? And many of these things, I think at this stage cannot, you know, we don't know what the real outcomes are. And I think with time, all of these things will be shared. But I think it's been a challenge because we've all been learning together and using the little data and evidence that's there as different countries publish on their experiences. We've also been trying to learn from that. And so it's been quite an interesting, challenging time, but I think especially for the obstetric fraternity because of the nature of the work that we do.
Great, thanks, Professor. That's you again bring up, and there's so many important aspects to this. You know, when you're talking about with the obstetric services, that we can't plan, you know, for that really, right? So, you know, same with whether it's for normal deliveries or for safe cesarean section, so I think that's really something that's important to keep in mind when we're talking about in this space. And I think the other thing, and I know we're going to come back to this, is what you raise is the collateral damage, right? So, because we're really, in this panel, we're not talking so much about the clinical aspects of it, it's really about the service delivery. And when you talk about missed antenatal care visits, women who aren't accessing antenatal care, aren't coming to facilities for delivery, aren't accessing family planning services. These are all things that aren't directly related to COVID, but those are the impacts. So it's great points that you bring up, and I know we're going to come back to that. So thank you so much. And I would like to now turn to Dr. Madeline. If you can share, again, kind of an overview of the experiences for Rwanda on the ground. I know that Rwanda's had really a quite successful response to COVID-19. So I'd like to hear a little bit about your experience. Thank you.
Yeah, thank you, John, and the team. So for the experience of Rwanda, as other countries, no one was prepared for this COVID pandemic. But with the experience of Rwanda, with the time we had this pandemic, we were in the preparedness for Ebola outbreak. So with the ongoing activities on that time, it was like in mid-March this year, everyone was somehow aware about the outbreak. So as Ingobji activity project that was supporting in Ebola preparedness, immediately we jumped, as Ebola was stable, we jumped into COVID-19 support to support the government of Rwanda to prevent the infection with this COVID-19. So with the existing resources, we supported the government, especially in infection prevention and control measures, where we supported in case management. The support was oriented on a national level, where we supported the national call centers, where we were like supporting in providing some staff in this for the call center, and we were like engaged in supporting in testing the suspected cases. Then we supported in capacity building of healthcare providers, even the community health workers. As we are engaged in supporting the government in the reduction of maternal and newborn mortality, our support was like to support the system, the government, to be able to manage this pandemic due to COVID-19, so that our maternity neonatal services stay stable. So as other countries, everyone was feared about this pandemic. So using the mass media supported by Ingobji activity as the government of Rwanda, we tried like to engage or to avail the messages, the clear messages for the community. So our focus was like, although we are in the pandemic, although we are in a lockdown, everyone was like, everywhere was locked, but the priority was given to the patients, including pregnant women and their children. It means with the existing health system structure in Rwanda, where we have the community level support with the community health workers. After the community health workers, we have the health post. The health post is serving like 3,000 people in the like 2 cells. Then after the health post, we have health center level, where we can serve like 10,000 persons. Then after we have district hospitals, then referral before referral we have provincial hospitals, then referral hospitals. It's tertiary levels. So everyone was engaged. First in a community communication about the pandemic, to have the clear messages, how the infection is received or transmitted, then how to prevent to get this virus. Then we were like supporting the government to give those messages, then to ask each level to support especially pregnant women and their children. For example, the antenatal care services delivery at all health centers continued as it was before. Although they had like some problem with the transport because of lockdown, but the local government leaders were engaged to facilitate those who need the transport means. It means like some sectors with difficulty in transport were provided with the vehicle, the cars to help those mothers as well as other patients who had their appointment to antenatal care or outpatient consultation. So the antenatal care continued, the family planning provision continued as well as in the community, because in our system, the community health workers can provide some method like injectables, some pills can be received from the community workers, health workers in the community. So we saw like the pandemic due to COVID disturbed everyone and everywhere, but with the existing system, the government tried like to support the patients, including pregnant women and their children. By this time, we didn't see much or increased maternal and neonatal death contributed to COVID-19 pandemic. The contributing factors were even before the COVID pandemic. So with the Ngobyi, we are still supporting the government because the pandemic is still there. So we are still supporting the health facilities where we provided the sanitation materials to the district hospitals, to the isolation rooms. And again, those treatment center for COVID, they are set in the ways to support even pregnant women. Recently, we had a case of COVID. It was a pregnant woman with a term pregnancy, and she was admitted in this COVID treatment center. She was well managed. At the end, she delivered in the treatment center. The baby and the mother, they are safe. After 2 weeks, she has been discharged from the COVID treatment center. She was stable with the baby. So although the government supported, we cannot negligent like some small or some consequences to the patients because no one was prepared before. So it means some people may fear to come to the health facilities because they are thinking I can be contaminated there. So the continuous media communication is continuous in each corner of the country to encourage everyone to seek care in case of need. Because with the support given to the government with the different partners, at least at each health facility, we have a screening approach. It means everyone entering the health facility is screened for the temperature. It means everyone coming, there is someone assigned at the entrance of the health facility where the temperature is screened. And the hand hygiene, hand washing facilities are available. And every Rwandan is using a facial mask, at risk a cloth mask. It has been supported so that everyone can get a mask at low cost. So with those measures, with those continuous mass media communication, at least every Rwandan knows how to prevent the contamination of the COVID-19. And they are aware, if I'm going to the health facility, every healthcare provider at least will try to prevent the contamination from her to me about this pandemic. And with this social distancing, although it's difficult for some areas where we have many population, they try to obey this social distancing even in the health facilities. Coming to the delivery rooms, post cesarean sections, all hospitals tried to look at the rooms specifically for all pregnant women, because a woman can come and can pass like 2 days or 3 days in the hospital waiting for delivery. So they're trying to make those social distancing be applied even in wards. So compared to the beginning of this pandemic in our country and today, we see some many of the Rwandans are no longer having such fear to come as it was at the beginning. Yeah, I think for the surgery, the planned surgery or emergent surgery are continuous in obstetrics, where someone or any pregnant woman who require a cesarean section to deliver the baby, she's received as usual. This is because with the community health, community-based health insurance, although she can have fear, but with the support of a community health workers and having this community-based health insurance, the pregnant women are coming in as usual. So no one is like losing her opportunity to deliver the child due to COVID, because the system is supported from the local government to the Ministry of Health to support each one who need any obstetric or neonatal care services. So we are on continuous support with the government. We hope, like with the existing structures, ongoing support from any partner from Rwanda or outside, we are on the way to see how we can end this pandemic together, because everyone's effort is needed to end the pandemic. Thank
Great.
you.
Yeah, great. Thank you so much, Madeline. And what I like hearing with that is really, and I think other countries can learn from this, is leadership is really important, and really that kind of organization of services from the top level all the way down to the community, I think is really important, in that clear messaging where everyone is kind of together on that, I think is really important. And there's, again, a number of things that you touch upon around the organization of services, not only at the health system level, in talking about those COVID treatment centers, as Mukey mentioned, in Ethiopia, but even within the facility itself, how that can help impact services, as well as reducing fear. And I think that's something we're going to come back to as well, talking about kind of even the mental health of providers, I think is important. We're going to go to another round of questions. I'm going to turn this over to Isioma to lead on that, but I want to encourage the participants, if you have, because now we're going to, after this next round, we're going to open it up to questions from the participants, to put your questions into the Q&A. Not specifically into the chat. The chat is if you want to just talk amongst yourself, but if you have specific questions for the panelists, please put that into the Q&A, and we'll be getting to that after this next round of questions. Great, thanks. So I'll turn this over to Isioma to lead the next round. Thanks.
Thank you, John, and thank you for summarizing all of that. So it's very interesting to hear about the experiences from Rwanda, Ethiopia, and South Africa. So Professor Masimwe, I know that you are part of the International Network of Obstetric Surveillance Systems. Can you please share with us or highlight what is coming out from the research involved in this group?
Thank you for the question. And so, like I mentioned earlier, I think my main contribution or my strong contribution has been being involved with the research. And so the international network, INOS, as they call it, is a research group, a multi-country research group doing multinational studies and mainly based in Europe, but more recently, African countries, I know Canada, America, there are other countries involved as well. And so at the beginning, I think around February, March, there was a call to say, let's all start collaborating, working together to find out what the impact of COVID is in pregnancy. So the study that we've been doing has been looking at hospital outcomes, so the women who've been admitted with COVID and how they do. And so some of the countries have published, there's about 10 countries involved: Ghana, South Africa, the Netherlands, France, Italy. And I mean, the work from the UK was one of the first countries that published, and I think that has helped a lot of people as well to understand. But the other advantage of being part of such a multinational study is being able to compare outcomes in low and middle income countries and outcomes in high income countries, where perhaps in high income countries, they might not have as many maternal deaths from COVID. And in our countries, things might be slightly different. And so, I can't speak too much on the results, but I thought I wanted to highlight that there is a lot of work going on. There's a lot of research going on. And the other thing about this is it's how the contribution of science and research to pandemics like this. And so we drew from some of the work that had been done previously with the H1N1, some of the work others have done on Zika. And so being able to do this as collaborators from different countries allows us also to prepare from a research perspective for the next pandemic, because even with trying to find the answers of what to do, developing guidelines, we had to draw mostly from research that had been done in other countries. So I think it's really important that whilst we are looking at the clinical outcomes, whilst we're looking for clinical guidance, health system strengthening, that research needs to be an important component for us to know what to do to get answers and also to prepare for the future.
Thank you very much for sharing that. And I absolutely agree that, of course, we've heard the experience about the systems adjustments that have been made in your 3 different countries to prepare for this, and also in response to previous experience with the Ebola virus, for example. But research should also be at the front line, because of course, such research can feed into the policy and the evidence-based practice that goes to informing guidelines and advocacy as well around the area. So thank you very much for sharing that. So Dr. Daba, in your discussion earlier, you touched upon briefly, and I think everybody has touched upon this issue about the impact of the adjustments various systems and practices have had on the frontline worker. So as we heard about in the very first bit of presentation, 70% of frontline workers are female. And I just wonder from whether you can speak to the experience in Ethiopia, what you're seeing coming through there in terms of any issues around mental health issues, any issues around retention of staff, any issues around recruitment of staff. Because of course, when we speak about resources in preparing for pandemic and future responses, the human capital is an important one.
Yes, thank you. As you've said, like one of the impact is about human resource. And if you see the total human resource we have in Ethiopia in relation to specifically obstetric care, we have only few providers initially from the outset. One of the things that this pandemic has brought into the surface is how much our healthcare system, our human resource, was already under the number that is required and already on a verge that we needed to do intervention earlier. If you see the total number of, for example, OB/GYNs, we have still less than 1,000. So you can imagine, for a population of more than 100 million, you can imagine the total number of providers we have. So if you see the impact of the pandemic and the impact when it comes to providers and human resource, most of the work that are at levels, starting from cleaning, support staff, if you see the total number of nurses we have, it goes the same way. It is, the ratio is still very small. So, but if you see like recruitment, because all those who have been at the front line continued and still are showing their devotion and commitment to come to the centers. And that is really surprising. Initially, there was some miscommunication, you know, whenever pandemics come and when things like this happen, there was a misunderstanding that some services were somehow shut down, especially essential services. Obstetrics and gynecology and delivery services were still continuing. Most of our midwives were very keen. They were stretching themselves, even when there are some stigmas that were related to being a provider. They were even easily picked because they be taking some public transport, they will go in public, and there were even some reports that we have encountered, especially for female providers. As you said, even population-wise, we have more than 50% of the population being women and girls. But still, if you see at different stages, starting from leadership level to the other supportive staff, they are more vulnerable because they are more at the support staff than the frontline level, even if we have still comparable number of providers, female providers at the front. So recruitment, we currently have even some physicians that are still struggling to get more employment, and it is a good opportunity now we have, because they are currently more working at some of the COVID centers, but some of the challenge is also protecting them. So we need all the PPEs, all attentions and trainings, extensive trainings should be done and had been on a way. So we are always advocating and saying that we have to make sure that women are more represented. Care have been disrupted. I will just give you one example. Even in our institution, one of a good example we had was we have a daycare for support staff, and sadly, because of the COVID, that's daycare has been already closed. So you can imagine some of the challenge this would brought on every staff that is working to bring this to an end, or even while COVID is going to continue with us, or until we get some results or even solutions to it. How are we making sure that we have women getting support during this pandemic? Be it because if you are working at a COVID center, for example, you have to be there, and at the beginning of the pandemic for 15 days, if you work there and there were some rotations for another 15 days, you had to isolate yourself. So there were lots of challenges coming, emotional, psychological, and women were, even everyone, I would say everyone, not just women and girls or anyone. So everyone was having that emotional stress and not knowing how to proceed. And currently, the Society of Psychiatrists, there are very brave women that are coming now that are trying to check if there are some key indicators if our providers are having some burnout. So these are very critical things to consider at every level. I think every country, how are we in response to addressing the psychological and mental, even economic aspect of COVID for providers?
Absolutely. I 100% agree with that. And you use that word burnout. That's a word those of us in obstetrics and gynecology are very familiar with, even before the pandemic. And it's just very interesting to just hear the experiences in Ethiopia. Thank you very much for sharing that. So over to you now, Dr. Mukashima. So I'm aware that Rwanda has had a successful response to the COVID-19 pandemic in relative terms. And we've heard about, the impact on the frontline worker and logistics and recruitment. And also some unfortunate sad stories about frontline workers being pinpointed. Have any health workers in Rwanda experienced harassment or attacks? And, how have you assessed or handled and managed attacks on healthcare workers, especially in maternity and child health care?
Yeah, thank you. For Rwanda, with this COVID-19 pandemic, as other countries, everyone was working under fear, under stress. And like Ethiopia, the majority of health workers in maternal and in newborn services are females. So with this pandemic, I think those females had like to work like under pressure as well as other healthcare providers, because everyone was fearing to be infected with this virus. So by today, we don't have exact scenarios with harassment to those female health workers from anyone. But with the beginning of this pandemic in our country, if you are a healthcare providers working from the health facilities where everyone was thinking to receive a patient with the signs and symptoms of COVID, when you were like working at the front line, everyone was like to say, maybe you have this virus. But with the harassment, like from the family members or anyone else, was not like, even is not present as you can see it. That's why I was like even suggesting to see if we can suggest any assessment among the healthcare providers in our countries to see if for sure there is any attack. Because with the government policy and procedures in our country, even if you can harass anyone, it's not obvious. So for my understanding, with the pressure those healthcare workers are working on, receiving suspected cases, treating the confirmed cases, maybe their family members, maybe their friends, maybe their workmates may show up like to stigma them, but it's not obvious because there are some policies we have to follow to prevent those harassment or those stigmatization of our colleagues. But with the assessment, maybe we can find some health workers who may confirm, like they meet someone who show up like any harassment type to him or her. So for today, we don't have like specific cases of harassment. Thank you.
Thank you for sharing that, and also sharing your ideas about what can be done moving forward, should that situation arise. So what we're going to go now to is to responding some of the questions that have come through. Thank you so much for the audience members sending the questions in. So I'm going to hand over to John.
Great, thanks Ethiopia and panel. Again, a great round of questions and responses. And we do see questions coming in. Please keep coming with them. I don't know if we'll be able to get to all of them, but we'll do the best that we can. I'm going to start with one. I'm going to change pace a little bit here. It's from Bunting Nang, who had a question, and this is, I don't want to say it's collateral damage, but it has this other impact that COVID is presenting. One of the challenges is around training and around capacity building, ongoing mentorship, because we know that COVID has impacted travel, has impacted in-person support. So how have countries responded to that? And I think with, especially with, things like obstetrics and with surgery, a lot of that is more kind of hands-on, type of capacity building that may not be as easily transferable or utilized for virtual support. So what has been your experience, and what is your approach to maintaining that capacity of your frontline workers? And I'm going to open it up to the panel. So please jump in with your responses, and we'll make sure that we get to everyone. Yes, next page, please.
Thank you so much. This is a very good thing to raise, because one of the things that our society, our OBGYN society tried to see was, because it's obvious that some services were already affected, and elective surgeries, because one of the things that all practitioners, and especially those who are residents or on fellowship on different practices, are really thinking was, am I really competent enough now? Because we were initially more talking about quality, while even our number was reduced, but quality was what was our motto. So in Ethiopia, for example, we have 13 teaching hospitals for OBGYN residency. So we try to do a study to check where they are in regards to how they are feeling, because we didn't discontinue, we haven't discontinued residency programs. Residents were still continuing to learn, but obviously different aspects, including, for example, antenatal care numbers, how you can do teaching rounds, how elective surgeries were scheduled, especially for gynecology cases. I've seen one comment that were saying even don't leave gynecology out of this obstetric discussion. And of course, that was severely affected, especially outpatient clinics and inpatient rounds. So the other thing was, most of our teaching also goes with our morning sessions. And like our morning sessions are usually packed, and we were not even prepared if we were initially can have virtual or electronic or tele medicine. So this is a very important to raise. Maybe it could be with service too, in addition to the teaching programs or residency programs. Because, for example, in Ethiopia, antenatal care, a woman might come with her chart or her appointment cards. We don't have like electronic or calling to them when they can come, or how we can schedule, reschedule their initial appointments. So everything initially just paused. So some of residents, we did some qualitative and both quantitative one. You can find this is still a preprint one, so you can try to see the one paper that we have on a way to be published that talks about impact of COVID-19 pandemics on obstetrics and gynecology residency programs, a perspective and adaptive ways of teaching that some institutions have started. So we were having discussion with residency program directors, fellowship directors, and had some qualitative interview, how they really have adopted to continue their teaching system. Because one of the things, whenever we talk about safe surgeries, quality in trainings too. So some institutions, because urban-rural disparity and institutional disparities really have an impact if we continue, or if you don't have standardization at national or international level. So this might be one of the things that I would call for an action maybe later, so that we can say, if emergencies like this come, or pandemics like this come, how can we proceed with quality and standardized residency programs. This can be at FICO level, it can be at different colleges like ACOG. Of course, you see different disparities if you go in different countries, but even our assessment later, could it be the same as the pre-pandemic? Because this is a good discussion we have. We're talking about COVID and post-COVID, or even with COVID. So are we going to keep internship evaluations or residency evaluations the same way? Should we change the way we will do some of the evaluation? So how can we compensate? So some institutions initially started to have Zoom. So morning sessions, for example, I will now talk more about the adaptive strategies that we came up with, was we started to have Zoom sessions coming. It's a very good lesson for us. Now we even learned that people at different continents can now join. Those who are already in leave or can also join us for their morning meetings and presentations, case presentations also. So it was a very good thing, but connections matter. We have to know where where we want to implement this type of methods, but it really have worked better. And the other thing was presentations on telegrams, where some the residents will put their PowerPoint presentations and different papers that they have reviewed on our group calls and group chats like Viber, WhatsApp. And the other thing that we did at our society level, for example, for ESOG, was we have started a webinar series for our members, and also they can give that link to their residents. So we started that webinar series about COVID initially, how we can change our setups, how we can do management. So this is an ongoing one. We have to listen from the residents and also from our trainees. It's a very important thing because we don't know how exactly they are feeling at this time. And we are seeing that the level of burnout and depression, and you don't have that much interaction like before. So we might not get a time to see how they are feeling currently. So mentors have to come forward and approach their mentees this time, be more supportive. So these are some of the things that came into the surface when we tried to do this approach. Thank you.
Great, thanks, Mukey. Salome, it looks like, Salome, I'm sorry, yeah, it looks like you want to add.
Yeah, and I'll just add, and I think what the important thing here is that, you know, we were already in a strained system before with you know, knowing that we don't have enough human resources, you know, across the continent to address some of the issues that we have. And so, you know, the immediate closure of borders also meant that some of our residents, registrars were in another country. Some of them are still locked out of the country. Also meant that the students are no longer in the platform, are no longer being able to assist and be there. And also issues like examination. How do you examine those who have finished their time but now, you know, need to qualify and be there? So it's been a lot of challenges, but I thought I wanted to just highlight that. And some of the innovations that we have come up with, you know, the use of telemedicine, and so how bringing in telemedicine, and I'm part of a pilot that we're doing in the Western Cape province in South Africa, where we want to use telemedicine to assist and to improve service delivery across institutions, tertiary institutions and district institutions. And so we've all been forced to be more innovative in how we do everything, and to work with what we have and to look for new solutions. So whilst it's a crisis, but I think it's shown us or put on the spotlight some of the problems that we've always had, and forced us to look at things and how we can do things differently. So it's the opportunities that come out of the crisis that we need to appreciate and use that towards strengthening the health system for the future.
That's brilliant. I absolutely love that.
That's great. Madeline, did you want to add anything from your experience in Rwanda?
Yeah, for the response on the teaching, maybe I don't have much to share, but I will share about the mentorship, because with our organization, our support to the government was specifically oriented in mentoring, health worker supporting in maternal, newborn and child health and the malaria programs. So with this COVID-19 pandemic, during the lockdown period, the mentorship were held for a moment, but now since like 3 months ago, we resumed our mentorship support and supportive supervision to the health facility levels. So we are still supporting our midwives, nurses, and medical doctors, supporting in maternal, newborn, and child health and the malaria programs. So we have mentors who are the health care workers working in our supported health facilities. The support is continuous. Even the Ingobji staff is allowed to travel to the health facility to continuously support the health facilities levels, so that we lose our mothers and our neonates. So there is like a need for everyone who is supporting this mentorship approach to obey or to follow the prevention measures. It means with the support provided to the health facilities, with the measures given by the Ministry of Health, they are followed by the mentors, the mentees, because our area of focus is like to increase the skills, even the knowledge of our health care providers. So even if we are mentoring, even we can arrange some on-site trainings. For example, now we are using low-dose high-frequency sessions for healthcare providers in their health facility working place. So it means you can take 5 healthcare providers and you train them, but following the measures provided by the Ministry of Health to prevent the transmission of COVID-19 pandemic. So our mentorship is continuous, our supportive supervision is continuous to ensure that our mothers, our neonates are safe, are treated according to the national protocol to continuously reduce the maternal and neonatal mortality. So for teaching, I don't have much to share because I'm not in academic area. Thank you.
Great, thanks, Madeline. But I think it's really the point of I think it's a continuous path, right? The training, the ongoing mentorship, and what I really liked hearing that's coming out of this is really that adaptive learning piece of it. And that's really what this is about. And it should look, as Mukey and Salome mentioned, it's, bringing in, some innovations and using that practically and learning about that. So whatever these platforms are, whether it's Zoom, it could be WhatsApp, it could be Viber, how do we use those, and it's about, yes, it's reacting to this current COVID pandemic, but it's building back better, right? It's because, things have changed. And, even if we're going to have post-COVID, it's not going to be the same as it was pre-COVID. And I think as Salome said, it's like it has forced us to kind of look at the challenges we already have and be, really be, intentional and creative in how we move forward with this. And this is obviously a huge area is about that building capacity and maintaining quality and safety. Great, so I'm gonna turn to Isioma for going through our Q&A list for the next round. Thanks.
Thanks, John. And I absolutely agree with what you just said. I remember a great quote from a teacher I had was, never waste a crisis. So there's challenges, but there's also opportunities. So absolutely. So the next question from the Q&A is a very interesting question about NSOAP. So the National Surgical and Obstetric and Anaesthesia Plan. And so the question is twofold. So for some countries like Ethiopia and Rwanda, who have implemented these national surgical, obstetric and anesthetic plans, as suggested by the Lancet Commission on Global Surgery, were some of these previous implementations useful in preparing for and responding to this current pandemic? And also, how has the pandemic slowed the progress in implementing the obstetric plan specifically? And that is open to any of our panelists. Thank you.
So perhaps I can go first. And I think one advantage in South Africa that has come out of this is, we finally started having, really serious discussions with the Department of Health on the South African NSOAP and developing that. And so I think with COVID and surgical care, immediately, the need to start to give guidance on what should happen with elective surgery and led to the discussion of reviving the work on NSOAPs and developing the NSOAPs. So we've got a national working group working on a long-term strategy of getting the South African NSOAP in place. So I think, again, so what COVID has done is highlight some of the healthcare challenges that were there before, but the public is more engaged.
No, it's probably easier if you don't mind, just so I can kind of keep it clear in my head.
So the public has been more engaged, and so the opportunity to start talking about policy advocacy, has given us more opportunities to do that. And even we have a SADC group, which has been very active, led by Emmanuel Makasa. And so, and it's with the pandemic, having to look for solutions, this has brought on more active work into these things. So I'm not answering the question, but I'm just giving the South African experience with the NSOAP in this time.
Absolutely. I think that's a very good point about how, so although South Africa hasn't got the NSOAP, this has provided perhaps the impetus to focus and develop that. And a question I have, just following on from that, we heard in yesterday's webinar from Dr. Mera about often surgery was referred to as the neglected stepchild of global health. But however, he referred to surgery more now as the poor cousin. And his reference to that was to the importance in planning NSOAPs and implementing NSOAPs to really think about the financing. So I wonder, would anybody on the panel be able to comment on that in terms of the sort of financing that has gone before or future plans moving forward, of course, for the obstetric plans?
Maybe, as you have rightly said, one of the areas like safe surgery and surgery as a whole was more neglected previously, rather than just the providers or the clients that need it or the patients, or the hurt we have for surgery. I think like globally, except now where even the SDG has embedded it in inside, because this is about even leaving no one behind. So if we are talking about leaving no one behind, it's about those who have access, those who have finance, those who have limitation, even for having a quality type of or even standard services at different quarters, different quadrants of the world. So one of the challenges that we really have to think of moving forward is sustainability, because most of the things around surgery and safe surgery are more of a program or a pilot thing or implementation plans. So sustainability should be something that every country, even like ministries, have to say they own it, because different innovations come, quality improvement projects come, and for a few months or for a few times they will be surfacing around, but later they will just be someone's problem than the whole country or the whole world's idea. So I think countries and even ministries at every country have to own safe surgery and quality improvement projects, and institutions have to show their commitment. And we as providers and surgeons have to always advocate every stage that we get to advocate for the clients we have and our patients, and to have safe surgery being the core agenda at every table that we get.
And just to add, I mean, and I listened to yesterday's talk, and then I agree completely with John on that. And also just to, so much progress has been made, global surgery leaders in Africa, that has changed. We've got leaders now, we've got people that are, even in medical schools now, I mean, medical students, we having webinars, teaching sessions, we've got groups, and that shows that, we've made a lot of progress, and we just need to keep going. In South Africa, there's 3 global surgery centers, which are fully supported by the universities. The whole language around surgery is starting to change. People are understanding these things. So we might still have a long way to go, but I think a lot of progress has been made. And I think the fact that we've got African leaders who are committed towards improving surgical outcomes, that is a huge step, and showing us that we're making a lot of progress with this.
Great. So I'm going to change pace again a little bit here, and kind of combining a number of questions in the Q&A and adding a little layer to it. So it's getting back to a little bit around, I don't want so much around talk about the clinical aspects of it, but really looking at the organization of services for cesarean section. Because I know, for example, Mekdays, you had mentioned, at the COVID centers that it sounds like the C-section rate is quite high. And maybe, you can talk about some of the research around that. So one, just kind of looking at the organization of services, like how patients are screened, treated, the indications for cesarean section, kind of how all that works, and along that continuum, how the providers are being protected from transmission. And to layer on top of that, I think is really, we haven't really gotten to, is the woman's experience for pregnancy. So for example, I think there's some challenges for allowing support, allowing the spouse or support persons on the labor wards. And there's some situations where the newborns are separated from mothers. So just wanted to see if you can speak to that a little bit, what your experience is and how you're managing that. Again, opening it up. Mekdays, yes, thank you.
Okay, thank you, John. And I have seen also similar questions around what you have already summarized. One of the things that we do is, I will start with the indications that we have for C-section. We haven't changed much of the indications for C-section. All obstetric indications are the same. Unless a woman have obstetric indication, we are still adhering to the same rule. So COVID is not an indication for cesarean section by itself. So but except if a woman have severe respiratory distress, or if there is an indication to terminate to have a delivery or termination of the pregnancy earlier, there was we even encourage not to have cesarean section until a woman was found to be negative, unless there is a need to have delivery earlier. So maybe one of the things that we were even discussing as a team in here was, why are we having more cesarean section for COVID cases in here? But I would come with some of the confounders, because who are getting the chance to get screened? And one of the questions that one of our anonymous panelists was asking is how they can have COVID screening for their cases, even they're living in Addis, where we see that most of the testing is being done in Addis compared to the out of Addis, which is the capital of Ethiopia. So most of the cases that are coming to institutions where they can get screening are those who have probably previous cesarean sections, who have indications to be at tertiary institutions where most of the testing were initially being implemented. Just last month, before the start of this month, the government has started to do scale up for the testing. Initially, we were having just only 100 or a few tests per day, which is now increased to an average of 15 to around 19 or 20,000 case screenings per day, which is significantly changed. And initially, the only people who can get screening access were those who are more near to tertiary facilities. So they probably had an indication from the outset. And some of the cases that we had, COVID center physicians were presenting initially, where they were telling us the details of every case when we have discussions. So most are either breaching labor if they were emergencies, and otherwise, most cases who will have an elective surgery were getting a chance to be screened. So it is not because that women were directly getting to cesarean section, but those who had an indication were being screened. So that answers some of the queries that you would have. And the other thing that was asked was, what is the ideal time to have a screening if you don't have routine screening setups? This depends on where we are talking about. Because, for example, for St. Paul's, which is a tertiary facility or referral setup, we're trying to do screening unless a woman comes with emergency for emergency deliveries, because we are not getting results back in few hours. So unless we have cases that we need to do emergency deliveries, we are screening almost all pregnant women. So, but this is not a setup for health centers or other facilities that are even giving CMONG services. So what we initially discussed with the ministry and the maternal and child health department was, how can we do our triaging? Because how can we make sure that both our mothers and also our neonates and also providers are safe in practicing obstetric surgeries or deliveries or every service, starting from antenatal care to postnatal care and other essential services. So for now, I think if we scale up the testing, that's why we always say we have to scale up testing. We have to make sure that it is accessible at every institution. Otherwise, if we just talk about one urban area or one facility or two facilities at the center, then having less chance to get to be found at the periphery, this will be a challenge. So the ministry has been trying. They say they are trying, and we are also seeing there is a commitment to increase the chance for scaling up testing. But the ideal time would have been if a woman had a chance to be having delivery soon, or that also depends on how soon we can have our test results on our hands. So maybe it all revolves around the type of test that we are talking about, like rapid tests, or talking more about PCRs. It might be different. Some countries have an access to get the result immediately. Even for us, we will not get results in 1 or 2 days maximum. Some private facilities have an access to do all screening for elective surgeries. Some don't. So if we say this is the ideal time, we might get into more confusion and more discrepancies. So I would say the best thing to have is have an access or work for increasing access for screening everyone, especially those who are working to labor and delivery, and those who will have elective surgeries or even emergency surgeries if we get a chance to have early test results available. That way we will protect both providers and also our clients. And maybe later I will get back to, are we having maternal mortality coming at a national level, or other essential services being disrupted because of COVID? The first 3 months, we were having data being generated, and there was a tendency to have home deliveries and less institutional deliveries because of all the reasons that we have initially stated, like fear of stigma, thinking that there will not be a service, thinking that they will get the contract COVID. All these things have contributed to it. So, but later, services like family planning, other things were getting better, but still struggling to get into the initial or the desired level. Thank you.
Great, thank you. Yes, Salome, just briefly, and then I think we're going to wrap up soon. So yeah, just please, thanks.
And I'll just touch quickly on the mental health issues, and just, you know, there's never been such a time as now to pay attention to the pregnancy experience, to pay attention to the mental health experience, because women are afraid. Women are afraid that their children are going to get COVID. Women are having to deliver without their spouses. Women are having to navigate around separation from the baby and all of these things. And so it puts a lot of, you know, as healthcare workers, we as OBGYNs, midwives, we need to pay attention to the mental health of women at this time.
That is a beautiful, that's a beautiful way to wrap that up. Salome, thank you so much. And I really appreciate you, Mukey, for pointing out that COVID is not an indication for cesarean section. So just want to make that very clear. This has been fantastic. It's been a great panel, and I'm surprised how quickly it went for me, because it was really interesting. I could continue on, but we do have to wrap up. And I'd like to just take this time, you know, as we wrap up, to do kind of a round from the panelists of a call to action. And so, what would you say? You know, what is your call to action for stakeholders in global surgery and in the maternal and newborn health arena? I think that sometimes those seem to kind of get divorced, but you know, we need to make sure that they're together. So what is your call to action for those stakeholders? I'm going to start with, we'll go in the same order that we started with the introduction. So start with Mukey, and then we'll go to Salome and then Madeline.
Okay. Thank you again. And one of the call for action that I will ask is we need to focus on protecting our health workforce and our mothers and children and also our newborns during this pandemic. And other than any other time, we have to know that the world have to work together if we really need to bring this pandemic to an end. So let us all work and join hands together, learn from what we are getting from science and research, and make sure that everyone is protected and we are all in this together. Thank you.
Great, thanks. Mukey, Salome.
A lot, I mean, from my work with cesarean sections, etc., what we've really found is that, you know, our health outcomes are only as good as our health system. And if we have fragile, weak, poor health systems, we'll have poor health outcomes. Maternal mortality rates, stillbirth rates might and will probably go up from this. So we need to invest in strengthening healthcare systems, especially in vulnerable populations. We need to reduce maternal mortality. We've got more work to do now, post-COVID, as now with COVID than we did before. So we need to strengthen all our activities to save mothers and to save babies.
Great, thank you, Salome. And Madeline, please.
Yeah, thank you. As all we know, pregnant women, neonates are among vulnerable persons. So all governments are request to think about those vulnerable persons we have in our society. So during this pandemic, even after this pandemic, we have to continuously build the capacity of our midwives, our medical doctors, our gynecologists, so that they are safe first to save life of those vulnerable persons. And we have to think about our health worker, our community health workers, who are the first one to support our mothers and our newborn in our community. Thank you.
Great, thank you so much, Madeline. And thanks, panel, again for joining and for those inspiring calls to action. And I want to thank Isioma for co-moderating this really interesting panel, the translators who've helped us with throughout this session, and the G4 Alliance and PGSSC for sponsoring this. So I'll turn this over to Laura for the closing.
Thank you, John, Isioma, and all of the panelists. What a great discussion. I feel like we could continue it for another hour, but alas, work calls. As John said, we're really thankful for the panelists, Carol Bales from the Frontline Health Worker Coalition and IntraHealth International, who's contributed greatly. Our translators, I'm sure it was brilliant. I look forward to listening to the webinar in French and Spanish. And thanks to Lifebox for your technical assistance with the interpretation. As you know, this is a series of 4 webinars. And yesterday we started with surgery. We have 2 more in the series. We have a webinar tomorrow at 11 a.m. GMT, which is 7 a.m. here on the East Coast of the United States, for an hour about trauma care. And on Sunday at 8 a.m. East Coast US, we have our final webinar of this series of 4, Anesthesia, Getting to the Tipping Point. So there's the link. Look on Twitter if you can't find the link to register. As Isioma said, you know, never waste a crisis. I love that. And I can see from the panelists today and all of those who participated in the chat that in maternal and newborn care, we're certainly not going to waste this crisis. I think we're learning a lot and applying it as we learn. And thank you all for your time today. This has been a pleasure. We'll have videos and recordings of all the webinars online available if you missed the first one or if you can't participate in all 4. So you'll see those on the G4 Alliance website. And with that, thank you. Muchas gracias. Thanks to the many partners, too many to name. You see all their logos. We're really thrilled that all 64 members of the G4 Alliance have contributed in one way or another to this webinar series. And see you tomorrow, hopefully, for the trauma care webinar, and have a great UNGA week. And stay safe, everybody. Wear your mask, wash your hands, practice physical distancing, and we'll see you online. Thank you so much.